report. This is Omar Khan. He is currently the Vice Chair in the Department of Family Medicine and the Medical Director at the Eugene DuPont Preventive Medicine and Rehab Institute. And he does a lot with our residency program. He has a global health resume that is longer than I could possibly explain to you, with tons of collaborative work in South Asia. And the best thing we sort of highlighted from his very kind summary that he gave to us is that he's had malaria 3 times. An interesting fact that most people don't know about him. But he says that this is less scary than going to Afghanistan to work with the World Health Organization on polio eradication. And with that, I will introduce our speaker tonight for Global Health.
Oh, thank you. Well, thank you everybody for coming. And so you heard a little bit about who I was, but this is who's really doing the presentation. And I'm just happy to be the front guy tonight for our Global Health group, which includes our Global Health faculty, Dr. John Donnelly, Dr. Carl Testa, and of course all the Global Health track residents, of whom Rachel is one, Dr. Emily Gochler in the back is another, and our partners, the Delaware Academy of Medicine, headed by Mr. Tim Gibbs, and the Delaware Health Sciences Alliance. So we'll talk a little bit about all those things as time goes on. So, all right. There's not much time, it'll be okay, it'll be fine. I say this because this is also the intro talk, and every 2 years we reboot the Global Health curriculum, and this is sort of the introduction to Global Health, which you do at this point so that the new residents and some of the medical students get a sense of what our Global Health curriculum is like, and maybe just have a conversation about all of our diverse experiences in it. So here are some of our objectives. We always have to state those. So what is Global Health? Why should we care? And of course you want to see cool pictures, so maybe we'll have a couple of those. We shall see. I may have exhausted my cool pictures on the first part of the slide. So I found when I go abroad, I really don't like taking pictures. I really have a difficult time taking pictures of people. I don't know if anybody else feels the same way, but I always feel like this terrible sort of eco-tourist going around and snapping pictures of poor people. So I actually don't have very many pictures I have more pictures of buildings than people. So this is the Delaware Health Sciences Alliance within which we fit. It's a cooperative between 4 organizations: Thomas Jefferson, University of Delaware, Nemours, and Christiana Care Health System, and we have many external partners as well. We work on a variety of issues, which you can see up there: community engagement, basic science, value, disease prevention, and of course global health is right in the middle of that, not entirely by accident. We have a Global Health Working Group that brings together people from across the institutions to work together. So some terminology you might be familiar with: tropical medicine, missionary medicine, third world. These have largely been replaced in some cases by more contemporary terms. So instead of tropical medicine, which you don't really hear too much, except when you go to the American Society of Tropical Medicine, hygiene meetings, you really hear more about global health. And international health is probably on its way out, and the reason for that is that international health used to be where we, in the rich, powerful West, would deliver care to them. And we realized that global health is really about more connectedness and interconnectedness across disciplines and across boundaries. So our health is also part of global health, whereas international health is really about the health of others. And so that term has disappeared a little bit. Third world has been replaced by developing countries, less developed, and the World Bank's term, which they use, low-income and middle-income countries, and sometimes lump them into LMICs, low and middle-income countries. So a little bit about who are you, as the caterpillar, I think, said in Alice, right? Who are you and who are we talking to tonight in terms of public health backgrounds and international work experience, and what have you done? So I'd be interested in hearing how many folks here have a public health background or interest or formal training in that area. So quite a few. So that actually number gets larger each year, interestingly. 10, 15 years ago, we asked a group of largely medical, nursing, medical student audiences. The number was essentially, well, me, but the relatively few people. How about international work experience? How many of you would consider yourselves as having worked abroad in some capacity outside the US? Great, it's the majority of people. leisure travel abroad, I usually ask if the answer to the international work experience is 0. So, you have to get people to raise their hands to something. So then I ask, hey, how many people have been to Mexico on spring break? And, we get a few people from that. What are some places that people have worked in? I'm interested. Melanie, did you raise your hand?
No, but when you ask about leisure travel
Yeah.
abroad, I went to the Soviet Union.
The Soviet Union, wow.
I went, not to Russia.
Not
I went
Russia,
to the
yeah.
Soviet Union.
Sure.
And so I got an accidental tour of the local hospital when I was wandering around, and I saw one, and I wandered in, and of course no one spoke English, and my Russian was rudimentary at best. And so they basically dragged me through the hospital until they found someone who spoke enough English. And when they determined that I would like to see their hospital, not that I had medical need, I was quickly shown out.
Ah, let's see.
So I got an inadvertent tour.
Any others who have worked in Eastern Europe? Africa? Sub-Saharan Africa? Yeah. South Asia? Other parts of Europe? Western Europe? Developed part of Europe?
No,
England,
no.
France, etc.
Not in health, but I did work in France for a year.
Middle East or Israel?
I went to school there, but I didn't work there.
Okay. So what is global health? So the Institutes of Medicine have defined this as health problems which may be influenced by circumstances or experiences in other countries. That's pretty much everything. And are best addressed by cooperative actions and solutions. That's a nice definition. Wikipedia actually has, I think, a more usable definition. It's a field at the intersection of several social science disciplines. Now that's interesting, social science. Demography, economics. Demography is the study of population distribution. Economics, epidemiology, political economy, and sociology. It focuses on determinants and distribution of health in international context, and it comprises consideration of population health in a global context. Well, that's very interesting. So what doesn't this include? What sciences doesn't this include? Medicine. Yeah. So what does medicine have to do with global health? So we'll talk about that a little bit today, but I hope to challenge your thinking a little bit in terms of what the role of medicine is in the larger spectrum of global health, and maybe help us think about our traditional frameworks. For those of you who are from this institution, you know that we are a largely medical institution. And I think it's important for us to think about the role of medicine in public health and population health, and how it fits into a larger system, because there is a larger system. Medicine is not the larger system. So I'm happy to have an argument on that. Sometimes when we have our consultant colleagues in the room, we do have arguments on that, which is fun. So it's basically a Western concept, this global health idea, right? So in Tanzania, people don't think their health is global health. For them, it's just their health. That's what they care about. Health issues of less developed countries, I think, is a pretty good definition. So why do we care? It's because most of the disease burden in the world is in the poorest nations. And the WHO Commission put it somewhat selfishly. They said it poses a huge threat to global wealth and security. It's an interesting way of framing the problem. We should care about global health because we might lose money. Seemed like not a very good reason. I like the next reason a little bit better. Hopefully the reason we're all here is that people die because of preventable and treatable diseases, not just infectious now, but also chronic diseases. And we do have the potential to save these lives in a very economical fashion, actually. We don't have to spend lots of money. But we do have to provide some basic services and support, and sustainable support. And that's what our curriculum hopes to train people to do. So why is global health important? Well, in the last 10 years, there are now 25 plus curricular materials on global health out there. And I've highlighted some of them up here. They're all fairly good. They all say approximately the same things. And if folks want to talk about this later on in terms of selecting reading, I'd be happy to talk to you about that. Now in Delaware, you might think, why do we care about this? And your patients, whether you're in Delaware or Philadelphia or Baltimore or the surrounding regions, they will have conditions outside of here. So there will be travelers, there will be recent immigrants, and there will be refugees seeking medical care. Anybody here from Jefferson Medical College? Yeah, Nitin, have you done a rotation at the refugee clinic, or a little bit about that? So you probably have seen some interesting medical conditions there. Yeah. Our colleague Mark Altschuler, who runs that program, he's given a talk here, and we'll probably bring him back next year to talk about that as well. Why do we care about these? These, again, it's because we want to provide care to those most in need. And it turns out residents want it. So 10 years ago, residents weren't talking about global health. They wanted to get an education and, get out of here. Turns out now they come in and specifically ask for this kind of training, especially in the primary care specialties, but not exclusively. So surgery, OB-GYN, pediatrics, certainly our nursing colleagues have always been on the forefront of providing care abroad. And the skills that you develop in global health are relevant to all specialties. I'm not talking about technical skills. I'm not talking about, doing, a thoracentesis in the field, with a penknife. I'm talking about stuff that you can use every day. That's cultural awareness, recognizing there's a world beyond our own, and not just the technical stuff. And guess what? You come back, and all of a sudden you realize there's a lot of that in the U.S., and that you can actually make a difference. Tomorrow you don't have to wait till next year to go abroad. Many of my colleagues do global health, equally engaged in community health. I think that's the real connection that we can help make over. Also helps us understand our healthcare system. So how many folks have been to any of the developed Western countries? Well, I could name anyone which has a different healthcare system than ours, but Canada, the UK, France, Germany, they're visited. Their healthcare system's pretty different. It's essentially a universal healthcare type of system. You don't realize that until you come back here or you witness somebody getting care abroad, and there's no insurance cards, right? You go in, you get your care, you walk out, somebody complains about that theoretical hip replacement that has taken 6 years. Sure, that's a lovely old wives' tale. And then you come back here, you have copays, you have insurance cards, and you have all the usual fee-for-service nonsense. It's different. It's different, and our curriculum helps to educate on that too. And I'll give you an example of how we do that. Important health needs for resource-poor settings, absolutely. Alternative health belief systems. That's interesting, right? So when you go abroad, and especially if you work in settings, Latin America, Sub-Saharan Africa, South Asia, you come across different ways of treating illness. So anyone been to a setting where people didn't believe that treating an illness with a medicine or a pharmaceutical was the first thing to do? Yeah. So, Carla, tell us about what did you experience?
When I was in Nepal, we had a patient come in, febrile illness, and the medicine doctors came in and kind of did some incense and chanting, and then we took over care of the patient after they were seen first.
Sounds sort of like rounds in the morning here. We go and we chant for the patient, and we go back and we chant at CPU, we chant at Dragon. We hope it all works. Any other experiences? Yes.
I just think we forget that people's faith beliefs are an integral part of their health. I mean, last week I had a patient arrive in labor and delivery, followed by 7 family members who are African American, and the first thing we did in bed is they were the full circle around her bed and prayer over her bed. That was the first thing that happened.
Yeah, sure, absolutely. Yeah. So important traditions that are part of healing, and whether or not we deliver care to the construct of a traditional Western evidence-based medicine, or if that evidence, isn't there room to incorporate traditional beliefs as well, if that's important to the healing of the patient, that's an interesting negotiation. I think many of you do that on a daily basis when you care for patients. So this is just a few things that anyone can sort of make this laundry list, but you talk to anybody who practices any form of general anything, medicine, surgery, OB, you will encounter something like this. In the last year, a sample of stuff. Testing PPD positive with prior BCG vaccination for tuberculosis in developing country. Okay, now what do we do? How do we protect against, as we're traveling, the acquisition of typhoid? Is there a malaria vaccine? No, there isn't. Is there an encephalitis vaccine? Yes, there is. You don't need it. Is there a diarrheal disease vaccine? No, maybe. Is there an HIV vaccine? No, unfortunately. Travel medicine types of calls. Unimmunized child going to polio endemic area. Anyone know how many countries still have endemic polio in the world? 4. Yeah, anyone know which ones? Take a guess.
I think Afghanistan.
Yep.
Iraq.
Nope, not endemic. That's okay. Keep going.
Oh, Pakistan. Right.
Yeah.
Not Nigeria. Right?
Nigeria, yeah.
Oh, Nigeria.
Yeah, exactly. So Afghanistan, Pakistan, Nigeria, Niger, depending on what month you're in, those 3, Nigeria, Afghanistan, Pakistan, always on the list. The fourth one sort of varies a little bit. But right now, I just got back last weekend from Bangladesh and Pakistan. Pakistan still has endemic polio, and if you're there for more than 4 weeks, you have to get a polio booster shot. Actually, it's not a shot, it's drops. They still use oral polio vaccine. And so you have to get OPV at the airport before leaving, otherwise you don't leave, or you show a certificate. So very interesting. I was only there for a few days, so I didn't have to worry about that. I'm sort of thinking about how that's still impacting the local population and the rest of the world. Last major disease to be eradicated, anyone remember that?
Smallpox.
Smallpox, yeah. Do we get a smallpox vaccine? Some military folks do. Generally, we do not. We do not get a smallpox vaccine anymore. Some of you are looking at your shoulder and thinking, I remember that 2-prong needle that I got. Yeah, but not anymore. Not since about the late 1970s or 80s or so. When polio goes away, one shot goes away from the vaccine schedule. We spend millions of dollars worldwide because we have polio in 4 countries. And so that will hopefully change in the next 10, 15 years. Okay. We may or may not get to this. I'd really like to focus on what we're talking about. I will, we'll send out this to everyone who put their email on, and you're nodding, you've seen the TED Talk on the
Gapminder.
The Gapminder talk. It's very cool. Some of you have already seen this before. I will send it out by email to you so you can have a look, and if at the end folks want to, we'll run this for about 5-10 minutes. Very cool, fun little display of statistics in global health, so we'll come back to it. Okay. Why is global health important, or what actually kills people, right? So let's think about that. So here's a top 10 list. That means you really cannot be wrong. So somebody throw out some ideas. What kills people? Yes, ma'am, you with the green shirt, you had your hand up.
Oh.
I know you were scratching your head, but that's okay.
The flu.
The flu, okay, so let's call it respiratory illnesses, shall we? Okay. Other things?
Cardiovascular disease.
Okay.
Trauma.
Trauma, okay.
I see
Diarrhea.
tuberculosis with respiratory.
Respiratory goes, yeah, absolute diarrheal disease and meningitis, maybe, okay. Meningitis, encephalitis, the whole
Postpartum
neurological.
hemorrhage.
Sorry?
Postpartum hemorrhage.
Postpartum hemorrhage, interesting, okay. Nobody named any tropical illnesses.
Malaria.
Big one. So let's have a look.
Until currently, Ebola was usually a very small number.
Yes, it's still, I mean, unfortunately, or fortunately, relatively speaking, of course, it's still tiny in the whole scheme of things. So here's the 10 leading causes of death in the world, and not just in the developing world. So you're not going to see a lot of those classic tropical diseases, but ischemic heart disease, number 1, obviously. Stroke, lower respiratory infection, COPD, diarrheal diseases, HIV/AIDS, developing and developed. Remember, this is a combination. This is not just something that happened to other people. It's happened to everyone. Again, the lower respiratory tract infections, diabetes, killing this many people. Road injury and prematurity, premature death, big deal. You mentioned postpartum hemorrhage, or that same spectrum of maternal child health. This is about 30 million people who died in 2011. So that's about 30 million deaths. Many of them preventable, by the way. Many of them in children, interestingly. So how do we impact this? Heart disease and stroke. How do you fix heart disease and stroke? How do you prevent that from killing people? What's the solution to that? You can throw whatever solutions you want. Anything from clean well water to cardiac catheterization.
Education.
Lifestyle and education. Okay.
Cigarette smoking.
So cigarette smoking, absolutely. Preventing it, I assume. Yes.
Monitoring.
Yeah. Okay. How about lung disease? COPD, asthma. Stop smoking, yes. But obesity. Okay. Sorry. Vaccinations. Lung disease, sure. What else for lung disease though? There's a big thing for lung disease.
Indoor air pollution.
Yeah, air pollution, indoor and outdoor. Absolutely. Yep. Diarrheal disease. That's an easy one. Clean water. Hand washing, clean water, and don't forget the flip of clean water, which is sanitation. So safe sanitation disposal. Without that, you don't have clean water, because guess what makes water unclean? Unsafe sanitation. That's the flip side. There's only one situation I've encountered where unclean water is beneficial, and that's for the spread of the polio vaccine. It's very interesting. Some of you might know this. The reason we use oral polio vaccine, one of the reasons, in developing countries, is because of poor water supply systems. You need a very high herd immunity level for polio vaccine OPV to work. You need like 95% plus to actually immunize an entire region. If you give OPV to a kid, they'll poop it out, gets into unsafe water. The particles get picked up by other immunized kids in the community. They get passive immunization through unsafe water. You can immunize 80%, you get 95%. It's very interesting. So HIV, condoms, what else? And? Yes?
Antiretroviral therapy.
Antiretroviral therapy, absolutely. It's gone to almost like that's the other flip side. You can keep somebody indefinitely living healthily with HIV essentially if you have them on a good course of heart. Diabetes. Lifestyle, but larger thing than that. You can tell your patient the lifestyle all you want, but they live in University of Wilmington, they got food deserts. What do you do? The kid goes to school, there's a vending machine, guess what the vending machine has? Right? You can tell your patient all you want. Get the sugar out of beverages, people. The 20-ounce things that poor New York Mayor Bloomberg tried to ban and got grief for that. That's part of the issue. Road injury. How do you prevent road injuries? Seatbelts, sure. Yeah. Stop driving.
Yeah.
You know where road injuries happen? Most of them? They happen in the country or the city? Most of them happen in the city. It's because country people come to cities in developing countries, don't really know how to drive, and then they're in a much more congested situation, and people are running into each other. The solution to this might be less in-migration into cities. Okay. So you got all these right exercise-built environment, food deserts for heart disease, for lung disease. I would say tobacco-free areas, tobacco regulation is probably a big part of that. Diarrheal disease, water and sanitation, of course, HIV, social behavioral and ARVs, diabetes, diet, exercise, and access, road injuries, again, mostly about the built environment. Prematurity is really about preventing early and unsafe pregnancies and access to prenatal care. None of these, interestingly enough, that you guys named, included us, people in this room. None of them included healthcare provision as a direct way to prevent this. Now, I'm not saying we don't make a difference, that's not my point. But my point is that big problems do need big solutions. And individuals going off, I don't see a catheter or a scalpel listed on this anywhere. Now maybe if I phrase the question differently, how would you improve cataracts? Well, okay, fine, cataract surgery, right? Or preventable blindness, diabetes, so forth. But the way the question is phrased, top 10 issues, how do you prevent them? You don't have to do with direct medical interventions alone. A lot of it is public health, structural, and much broader than us. Okay, so stethoscopes won't do it. They alone won't do it, right? So my apologies to my friend Paul Farmer, who's a wonderful man, but he himself would say that he has done the world a great injustice by being this sort of global health figure. When we think global health, we think Paul Farmer. We should be, and I think he'd be the first one to say that that's not what he wants. But if we think of great community-based treatment of HIV and tuberculosis in Haiti, yes, we should think Paul Farmer. When we think global health, we should probably be thinking of taking the handle off the Broad Street pump in England. We should be thinking about John Snow, we should be thinking about epidemiology, think about engineers, think about structural solutions. But that's less exciting, less sexy than the one hero. So, except for certain situations, I'm not big on the one person, one solution model. So it does mean thinking big, vaccines and education and supplies, maybe universal health, maybe political change. How many of you have heard about the Affordable Care Act, also known as Obamacare? You may have come across it somewhere in your travels, I assume. Okay. So that's a big deal. That's the biggest thing to happen to this country since Medicare, probably. It's a huge deal. But that's the kind of change that it sometimes takes. Notice I didn't say it's a good thing or a bad thing, I just said it happened. Sometimes it's the weakest link. When I was working in Afghanistan and Pakistan on polio, the biggest thing was improving vaccine supply at the local level. Because if we weren't improving that, kids weren't going to get vaccinated, and guess what? Polio would still be endemic in that country in 10 years. So what we've learned so far about solving big health problems, yes, it needs money, it needs commitment. Oh, speaking of money, how much of our GDP in the US do we spend on global health and foreign aid? Someone take a guess. You say less than 1%. Yeah, what do you know? You're just a global health tracker. Other people?
Ask it as a fraction of the defense budget.
Yeah, that too depressing a statistic, sorry. So total numbers, less than 1%, greater than 1 to 5%, greater than 5%, 5 to 20%, greater than 20%. Who thinks is greater than 20% of GDP? Okay. Who thinks is between 10 to 20% of GDP? 5 to 10%. Maybe. 1 to 5%. Okay. 0.5 to 1%. Less than 0.5%? That seems very sad. So it's 0.19% of GDP, right? So in a recent survey, this was actually about a year ago, Americans across the country, the Pew Trust did a survey. So this is not just people who are in health systems or people who know a lot about international development. Americans think we spend about a fifth on sending money over there, right? 20% of GDP. You're right, that would be more closer to the defense budget. But they thought we should spend, then they were asked, well, okay, if you think 20% is too much, how much should we spend? I said, well, 5%. 5% sounds about right. Well, if we did, that would be 2,500% more than we actually do. We spend 0.2%. So we're talking about fractions of fractions of fractions here. We don't spend a whole lot of money on this stuff. Oh, by the way, anyone read the News Journal this morning? Read the letter section of the News Journal. So go home, read the letter section of the News Journal, right? There's this guy, letter writer, who has written a letter about the CDC is sending 3,000 health professionals to Africa. He's very upset about it. He's not happy about us helping people in Africa for Ebola. His reason is that we will get Ebola from sending those people.
Right.
That's what you get. That's what you get. Okay, so I like this cartoon. My pen friend has anticipated it. So that's a leader who looks suspiciously like a previous president of ours, who is offering a piece of pie, approximately 0.19% in size of war budget, to African hunger. That's sort of what global health policy in many countries looks like. Who's the biggest donor, do you know, by GDP in global health?
Somebody in Scandinavia.
It used to be. It was Sweden. Yeah, it was Sweden. They got overtaken this year. It's the United Arab Emirates. Yeah. They spend 1.3% of GDP, a massive figure of 1.3%. There we go. Okay. So, yes, biggest gains in global health, as we predicted: vaccination, hygiene, improved education for females. This was a non-intuitive finding that came out about the time when I was in graduate school, sometime in the mid-90s. And a couple of researchers looked at what happens when you invest in certain social factors in developing countries. And this grew out of a pilot study in India. And it turns out that improved education for females gives you the most bang for the buck if you are looking for a community-based intervention. More than a pump, more than a tube well, more than virtually anything. It's so foundational. And you think, well, why improve education for females? So why improve education for females? Yes.
Because females may get together in a community and talk to each other, and they also influence their children. And they said one of the biggest ways to get boys to not go into the armed forces is to talk to the mother.
Fair enough, yeah. What happens when women get educated? They will tend to become economically empowered as well, right? What happens to money? So when the World Bank gives money to loan programs and development programs, they absolutely insist, based on the lessons of the 1980s and 90s, they insist that the money be given to women. So we just got back from Bangladesh. My wife was doing some work there on a World Bank project, and it's pretty much the natural thing there. The guy cannot go to the outlet to collect the check for that month as part of the program. Why should women get the money? Why shouldn't men get it? What do they tend to do? They tend to leave. Yes. Yeah, it's interesting. Men are fond, in general, massive generalization, fond of more leisure type activities. It tends to be spent on alcohol and things that do not necessarily lead to your children's improved nutrition, and unless of course it's alcohol. In the case of women, it tends to go to exactly what the World Bank and other development agencies are looking for. It tends to go to child nutrition, and that's been shown over and over again. So massive generalization, part of it true. So access to choice-based reproductive health services, really, really important. This is evidence-based statement, not a political one, but access to safe and effective contraception, very effective. shown reliably to reduce abortion rates worldwide, more than anything else. More than any abstinence program, access to contraception reduces abortion rates. And that's sort of an apolitical thing everyone likes.
And women who are educated tend to be more open to contraceptive choices, tend to space their births, which improves women's health.
And the child's health, absolutely. Yeah, exactly right. So this is, by the way, what happens when, on the way to the airport from this. The first one is Uganda. Second one is Thailand, I believe. But billboards, let's talk about sex. Billboards with flavored condoms. All they're doing is talking about sex. I mean, talking about reproductive health. When was the last time you saw a billboard for safe sex or condom advertisements in the U.S.? You drive to Philadelphia or BWI or inner city Wilmington or anywhere in the U.S. But we're supposed to have these discussions. I mean, it's a problem, and yet we don't have them. Good thing is other countries are starting to have them. So I like this cartoon as well. This came out when the HPV vaccine first came out, and the doctor is trying to tell these folks, I'm very sorry to tell you this, but your daughter has HPV-induced cervical cancer. Of course, the parents are just, all they hear is no sex. For those of you in general medicine, you know what it's like, trying to explain to the parent of a 10 to 12-year-old that you will be offering their male or female child the HPV vaccine, and them asking, why? Tell me more about that. And thinking, okay, this is going to be an interesting talk. Especially for boys, interesting talk. All right. We've talked a lot about the social determinants of health, and the determinants of health are supposed to be these 5 things that the WHO has talked about: policymaking, social factors, health service provision, individual behavior, biology, and genetics. All important stuff. Social factors are said to be among the most important influencing our health. This seems like it's obvious, but we don't base health policy around this. Interesting, in the US, when we talk about health policy and Congress authorizes money for health, and you say, well, if they're authorizing money for health, well, then they must be talking about all of these things. What are they actually authorizing money for? What does the money actually go to? I'll give you a hint. You're here. It goes to hospitals. It goes to a hospital because hospitals are easy to fund, and they're an easily conceivable outlet for money, and they do good things, and we take care of people, all of which are true. We do very good things. We take care of people. This is much more diffuse. How do you fund social exclusion? I mean, how do you say, I don't want people to be lonely, I'll give you $10 million to fix that? That's a really diffuse problem. And yet, social exclusion is a direct determinant of, think about domestic terror attacks, think about depression, think about suicide in adolescents. That's social exclusion which does that. That's a fundamental, and I mean, that's an idea waiting to be funded, honestly. Unemployment, social support, addiction programs. I mean, anyone heard the term NIMBY, not in my backyard? When it comes to needle exchange programs, no one wants them. Everyone thinks they're a brilliant idea for somebody else. No one wants a needle exchange programs with those people, in your neighborhood, right? So that's an issue too. Food and transport. There's a guy called Jack Geiger. Anyone ever heard of Jack Geiger? Yeah, you have. Okay. And do you remember anything? Why he was so famous? He founded Physicians for Social Responsibility. He also founded the community health center model in the U.S. And Jack Geiger is famous for having said, among other things, that he was going to write prescriptions for food for his patients. And when he was questioned by the insurance administrators, he said, my patients' problems is not medication or sickness. They're hungry. They're poor. I think he was working in rural Appalachia at the time. That is absolutely the main problem that they had. So, important stuff. The poverty trap. The future of a child is determined by the home they were born, the place in the world, initial health and nutrition, and education level of the parents. Does this sound right? It sounds right. The trouble is our policies aren't based on this at all. And partly it's because we're still a bootstrap nation, right? We like to believe you can rise from whatever circumstances you're born in and improve your lot in life. That is completely true. That is absolutely true. It's an empowering statement, and it is true. But for too many people, this disempowering reality is also the case. Where you're born is how you're going to live and how are you going to prematurely die, unfortunately. So that's a big deal. So that's the part which we have to fix. We can't just say, well, the resources are out there. You guys should go to the library and get an education and go do this and rise up out of poverty. Well, it's a nice idea. It doesn't work though. We've known that. So politics aside, certain things work and certain things don't, and that policy doesn't. Okay, Millennium Development Goals are, I will not go through them except to say that they're grand and big, and the world's countries have agreed to make these happen. Notice they have not set a timeline. They have basically said we want a wonderful world without disease. That's how it can be summarized. They have broken it down into specifics, and there are organizations devoted to helping us reach these. Child mortality, maternal health, they're general goals. But I want you to be aware of them because that's part of the global health dialogue that's happening. So, all right, enough talk about this. How about health missions? People like to talk about health missions because we go on health missions all the time. So this is a general approach to health missions that I find. So someone says, you know, I have a pretty nice life. I'm a physician, I'm a medical student, I'm a resident, I'm a nurse, I'm a respiratory therapist, whatever the case may be. And I want to go abroad and help people. I think that is a great idea because it's based on really, really important and wonderful ideas. So whenever you want to help people, hey, that's how we got into this. The question is, what's the most effective way of doing that? So when was the last time someone who went on a health mission, tell me a little bit about that. When was the last time somebody went abroad to work in a mission type program, health delivery, direct health delivery type thing? I promise I won't make fun of you. Okay, I will. Nathan, you went, where did you go?
2010 to Ghana.
Great. How much money did you spend to get in there?
The other $2,500.
Fair enough. So I would say that's a very worthwhile investment in education. So if one has to go abroad to see the types of health conditions that people are being affected by, amazing investment. You can't put a price on that. My only issue comes up sometimes when we spend that money over and over again, year after year, on putting band-aids on problems, which if you just look back and say, you know, I took 10 people to X country, I don't know, I'll pick on Haiti because it's my favorite country to pick on. There's entirely too many Americans in Haiti. We go to Haiti, we help people, we come back. You know how much money Haiti has received in terms of travel and other expenses that people put in the last probably 2 years? I think that's the right figure. Almost $100 million. Well, if we put in a tenth of that, and just rebuilding the water supply in Haiti, Haiti's problems are solved. I mean, that's the problem. The thing is, there's no way to channel our resources aside from the individual, let me go and help, and let me fix this bigger problem. We give money to UNICEF, we give money to WHO, it things disappear, and we don't know what happened to it. So I recognize the balance there. But so medical missions is a tough one. It can be fun and exciting and can give short-term benefit to a group of people. So that's good. If you connect with a health plan, a larger plan of some sort, it's a useful way to train local health providers. So I would ask if you go on a local health mission anywhere to help people. You know, good for you, your choice. Make sure you do something sustainable. Train somebody local to do what you're doing, and ideally put yourself out of a job. You know, if you don't have to go back in 3 years and they say, hey, you know what, we're doing good. Guess what? You did the right thing. I mean, you may have to pick a different spot next time, but you know that's exactly what you should be doing. As I said, for learners, I think it can be useful, and of course, think about why you're doing it and not impose those values on the people that you're serving. So why do we need formal education and training around this? Well, the American Council for Graduate Medical Education says so, the Association of Schools of Public Health says so. And in the last 5 years, we've had a lot more talk about global health isn't just getting on a plane and taking off. It's a set of disciplines, as Wikipedia tells us, and we have to learn about the specific disciplines involved so we can figure out what's the best investment to make of our time. The CDC says so as well. So here's stuff you will see around the malaria cases at UK airport. They have weekly stuff about influenza, travel-borne diseases. This is just from June 26th, not very long ago. Evidence for camel-to-human transmission of MERS coronavirus. People have heard about MERS, right? Middle Eastern Respiratory Syndrome. I remember the one that came before, SARS, right? So, so exciting stuff here. And in case you're wondering how the camel-to-human thing happened, it was the camel had rhinorrhea. And it was transmitted to the human like that. So, some of you may have heard of the little African disease called Ebola. So, big deal. This is from the CDC's website yesterday. 50% case fatality rate. 50%. Highest of any known modern disease at this point.
That's good for Ebola historically.
Yeah, I mean it used to be 100%, but this is 50% with prevention. I mean, there's folks who died taking care of people doing this. So, So we need to absolutely have curricula in place to teach the right things, I think, and perhaps to unteach some of what we might call the wrong things, and to teach the most effective ways to prevent disease and improve health. So Christiana Cares program, I think, is very nice because it starts with excellence, our historic excellence in primary care training in general. We have a core group of faculty in global health, both at Christiana and the larger Delaware Health Sciences Alliance. So in 2012, we did a survey. 100% of residents said, we want a global health program. Well, that may not actually be precisely true. Chris Prater, for those of you who know him, is a resident who graduated last year. He conducted a survey. The actual figure wasn't 100. Carly, do you remember what it was?
It was
It's pretty high.
80-ish,
Yeah, it was high, yeah.
round up to 80.
It was 20% who said we want a global health track. It was 80% who said we want a global health education program like this, come to a lecture, do things of that sort. Since 2000, we've noticed actually in medical education, I'm sure some of you have, students ask this question a lot. So this year, again, trending up, whether students applying to nursing school, to graduate school, to public health school, to medical school, to residency. This year, I would say, 8 out of 10 applicants to the family medicine residency program have been asking about this, like, hey, so tell us about global health. What do you guys do in that? That's a tough question to answer if you're not doing anything. And say, well, we train you to be doctors to do everything. Okay, but we don't give you specific training. So important stuff here. So our goal is really to create global health education that fits the needs of our staff, our students, and our residents. So how do we structure the program? Well, fairly simply, you haven't heard a whole lot about departments so far, and that is intentional. There is no one department that runs global health. We thought it would be very silly to silo it into a certain place. It's essentially open to the entire community. We do allow individual adaptations. We have tracks in certain departments who have wanted one. Internal medicine, med-peds, family medicine, and the combined family medicine and emergency medicine program. They have tracks, so to speak. We have a broader model than just the direct delivery model. We say that you don't have to travel to do global health, hopefully for the reasons that we talked about. Much of global health is not from medical disciplines, so that's also a little bit interesting. And we talk about the programs. We go to conferences. We present. We say, hey, this is what we're doing. What are you guys doing? It turns out that not as many medical institutions are taking this approach to global health that we did de novo. And I think that's kind of like Christiana Care in general. We may not, we're not the Harvards of the world, but because we maybe came to the scene a little bit later than some other folks, we can develop a new model which sometimes builds upon the best practices of others. So I think we've done a nice job in that area. So, set of core lecture topics, which is 11 lectures a year, which this is part of one of those. The topics reset on a 2-year cycle. We are now in the 2-year cycle. And of course, we encourage literally anybody who's from the Christiana Care community and community physicians, folks who, the Christiana Care community is very inclusive. Essentially it includes anybody who can get here. So anybody who wants to come is part of the community as far as I'm concerned. We have 2-3 grand rounds a year, and we've had really great speakers actually. We had the Associate Director of the NIH come to speak, Tom Quinn. We had the guy who eradicated smallpox, D.A. Henderson, come. We're going to have, on November 6th, we're going to have Walter Strauss come, who's the Vice President for Merck for Global Health. And you think, why does Merck care about global health? And anyone know about Merck's connection to global health? It's very interesting.
I think it's not vaccines.
It's not vaccines, it's a provision of a drug. And it's a provision of a drug called ivermectin. And ivermectin's trade name is Mectizan. And the Mectizan program has been going on since, 1982 or something like that. And ivermectin is used to treat tropical parasitic diseases. Anyone know any particular ones? So tropical medicine textbook, step one questions. So things like river blindness, loa. So it's a big deal in developing countries, especially in Africa. Well, it turns out Merck made a whole lot of money off of ivermectin for a completely unrelated condition, canine heartworm. So, and if you have dogs, for example, you probably have given your dog HeartGuard at some point, or something very much like it. HeartGuard is ivermectin, and Merck made a fortune off of it. So there was this guy who brokered a deal with Merck and said, listen, you can build yourself a whole bunch of goodwill, a bunch of tax breaks if you start this program. And they did, but to their credit, they said, we will continue it indefinitely. Indefinitely. No end date. And so Walter Strauss is going to come and talk to us about the public-private partnership of the ivermectin program for disease eradication in developing countries. All came from K9 Company. A very interesting guy called Adil Mahmood, who was at Case Western, who actually broke that deal. So we have the Holiday Symposium, we have the annual DHSA Global Health Symposium. How many of you have been to the DHSA Symposium? A couple of people? It's held once a year, obviously, it's annual. It was at Jefferson last year, this year Christiana, and next year will probably be at the University of Maryland. This is what our curriculum looks like. So we have some of the classic things like infectious diseases and malaria and dengue, and we have some things not so traditional like Millennium Development Goals and social determinants and ethics and chronic diseases. We have an annual resident presentation on the global health experiences. We have skills workshops, a kind of a mix, bringing the medicine and public health piece really together for global health. This is a certificate track that I mentioned, which is a structured education for residents largely. Here's some requirements. These are our graduates and graduates to be. Dr. Testa is actually a first graduate of the Global Health track in MedPeds. Subsequent graduates are the famous and data altering Chris Prater, Audrey Berry from OB, Poonam Maru from medicine, and then we have our current track residents, of whom we have at least 2 here right now. So exciting, and as you can see, it's across disciplines, many different specialties. We're always open to more who are interested. If colleagues in nursing or respiratory therapy or pharmacy want to start a global health track, we would be happy to talk more about that. Okay, how do we get abroad? How do we actually get the money to do it? Well, there's not a whole lot of money for this, I'll say this. It's tough to get money because when you go to a donor and you say, I want money as a medical student to go to a developing country, they think, well, okay, but you get your education in the US, we're going to spend $3,000, your figure is right about, for you to go abroad. Why would we give you $3,000 and not give $3,000 to somebody who can vaccinate literally 10,000 villagers for the same amount of money? It's kind of a tough proposition. So you have to look at it as an educational investment, and there are folks who will do this. So the American College of Physicians in Delaware runs this Bakshi Fellowship, which gives 2 to 3 travel awards a year. The AAFP, American Association of Family Physicians, gives international grants. The American Society of Tropical Medicine and Hygiene has a fellowship as well. You can always sublet your apartment. This worked better when I was in Vermont because, people go to Vermont to ski. I'd always tell the students, you should go in the wintertime. It actually worked great, right? Between December and March, you can absolutely sublet your apartment to skiers from out of town. And you can go to a nice tropical country, right? So Delaware, I'm not sure you can sublet your apartment in Hockessin, for anything, but still. Okay. 3 specific elective things I'm going to tell you about. The first one is our partnership site in India. It's at the Nehru Medical College. It's in Belgaum, which is near Goa. It's in South India, very pretty place. Richard Derman is the PI of this project. This site was the first one to show that you could use oral misoprostol in the field to prevent postpartum hemorrhage safely. Until that time, you couldn't do that. The WHO said, no oral meso in the field, you can't do it, you'll have all sorts of side effects. It turns out you can. And actually, when done in the right way, you can prevent a lot of morbidity and mortality doing it that way. So Richard and his colleagues actually showed that at the site, we are interested in having residents, students, others who want to go there for a 1-month type of rotation observership. You can certainly talk to us about that. We are part of the global network of maternal and child health research, women's and children's health research. That is an international network, and we're NIH funded to do this work. In Bangladesh, this is our primary partnership site called ICDDRB. It stands for the International Center for Diarrheal Disease Research of Bangladesh. Some of you may have heard of it or been there. It's one of the largest tropical medicine research centers in the world. They don't need our help. When people think of going to India and Bangladesh, and, I'm going to help poor people. Well, you could, but here we go to learn. And the cholera vaccine was developed here. The ORS formula was developed here. A lot of exciting research happening here. If you look down here at the very bottom, you can see this website is very simple. You just go to the site and it'll pull this up. it says International Field Experience Application Form. You fill it out, you talk to your program director, you essentially will get accepted once you talk to one of us, and then we figure out the funding. You go there for a month, everybody's had a pretty good experience. These are just some photos from Bangladesh. This is not my most recent trip, but the one before that. Anyone want to guess the level of dehydration this poor child has with the Cyclone Fontanelle? This is their main research center out in the field, largest demographic study in the world, still ongoing since 1971. This is us in a cholera ward here, and it's called a cholera ward because seasonal cholera is a big deal. This bed has a red rubber sheet on it. You can probably guess why it's a rubber sheet. It also has this bucket directly below it, with a hole leading from the bed directly to the bucket below it. Probably don't have to use your imagination as to why that's the case. These are called cholera beds, and I don't know where this was first developed. It's certainly never been patented. The rumor is this was developed here somewhere in the 1960s. Just an item of necessity. Didn't make sense to keep thinning up sheets. It made sense to do it this way. So the IV pole is right next to you. Although the treatment for cholera, which is uncomplicated, is not intravenous. It's oral rehydration for the most part. They also have a Nipah lab. How many places can you go to which have a Nipah virus lab? They study the Nipah virus of all things. It's a bat-transmitted virus. So biosafety level 2 lab here. This is completely different. This is our UK site. This is in the lovely seaside town of Plymouth. And a couple of our residents have gone here. And we have a collaboration with them and a memorandum of understanding with them. They look very much like us. They're a large multidisciplinary academic health center with a university and a medical school and a hospital and undergraduate campus and all that. So they're like the DHSA. We go there to study health systems. We go there to learn about the National Health Service. Residents have gone to work in the primary care clinic and see how does primary care work there? How is it different? How do you guys save money in it when we seem to be spending it? What are the similarities? How can I bring that back to my practice here? So different kind of global health, but this is what I mean about the new definition of global health. It's not just developing countries anymore. So I would say define the model that you're interested in and your current knowledge and awareness, and of course your motivations. Figure out what you want to learn. Do you want your first exposure? You have some previous work. Is there a level of vocabulary that you have to maybe get in the field? And of course you have to follow the 7 rules. I like this rule the best. If you insist on working with the poor, at least work among the poor who can tell you to go to heaven. So this is this radical priest who emigrated to Mexico in the 60s. And his approach was that poor people do not want a charity, they want help to be enabled and empowered. And that's really what the school is saying in a slightly more graphic way. This is obvious, right? Don't practice without a license. Stick to your specialty. How many folks do have gone somewhere and done something that you would not have done here in exactly the same fashion? All of us probably have this to some degree, right? We've done something. As a medical student, somebody's gone and sutured something and the attending's been like, you know what, you go take care of those people, there are too many sick people, I'll go take care of these people. Okay, yeah, fine. I mean, when that person gets a complication though, that's a problem. I'm not saying there's an easy solution to this, but I'm saying we should be aware of the ethical conundrum in doing stuff abroad, which we would not do here. So this rule does not suspend itself after going abroad. So just as it's here, it's abroad. As a Christianacare resident or student, you are applicable, you're bound by the laws of Christianacare more or less when you go abroad. You're covered by our malpractice, so don't do something that will make us regret sending you abroad if you're a resident. As an employee, that's different, but as long as you have a Christianacare badge on, you are at the hospital. Take it off, talk to your boss, do your own thing, absolutely. Maybe don't travel. I like this rule too. Think about what you want to accomplish, and if you've already traveled someplace, the best way to support this group is to do something different financially or human resource-wise or training. Maybe think about that. Create awareness. I mean, when the Boko Haram thing happened in Nigeria, we didn't have to travel to Nigeria to raise awareness about these women who were being abducted. We could raise awareness here. We could go to Congress. We could say, listen, this is a big problem. We need to devote some resources to this. So start a campaign, join a campaign. Get a public health degree. Most of global health isn't medicine, it's public health. And just as public health people wouldn't walk in here and say, I'm going to go to one medicine lecture and tomorrow I'm going to practice medicine. we shouldn't probably practice public health in that degree either, or some training in it. And I think that's important to think about, consider if you want to make a career out of global health, consider getting formal training in it. If you want occasional experiences in it, then that may be a different situation. Of course, you got to join the global health track, that's obvious. Okay, so this is my final slide. So the moral test of government is how it treats those who are in the dawn of life, i.e. the children, the twilight of life, the aged, and those in the shadows of life, the sick, the needy, and the handicapped. Anyone know where this quote is from? It's from a US government building. I'll give you that hint. Take a guess. It's an obvious one.
Lincoln Memorial.
Sorry? It's a health building. It's the US Department of Health and Human Services, home of Medicare and Medicaid in Washington, D.C. And also, interestingly, the Office of Global Affairs houses in the Hubert Humphrey building. So, good stuff there. I promised you pictures. Here you go. So, anyway, that's it turned out when I was traveling to Afghanistan, you don't technically actually sort of need a visa to go to Afghanistan if you're on the border. That's because there isn't technically actually sort of a real border. I think at half the time we were working there, we were on one side of the country or the other. I don't really know. The Welcome to Pakistan sign is sponsored by Pepsi, of all things. So that's sort of interesting. Anyway, that's the vehicle we traveled around in when we're doing our polio eradication work. I do a separate eradication talk, which we will talk more about perhaps in the future. On the left is an unfortunate little girl who, as I said, I don't take pictures of people. It doesn't mean other people don't. That is me testing a little child who had acute flaccid paralysis, and we were hoping, this was 2006, the WHO said we would eradicate polio. We were hoping we would see it being eradicated. That's why I was there to help write a book about polio. Well, we did eradicate it. That kid did have polio, unfortunately. I asked the family, why didn't you have your child vaccinated? I mean, these vaccinators are everywhere, swarming the country, saying, come to us in large conspicuous vehicles like that one, and on foot, literally everybody's an army. And they said, well, we weren't really sure it would work, and we got these rumors that it would make our daughters infertile, and the boys would be handicapped, and so forth. And it's like, okay, well, I guess that's, if my patient from Lancaster, PA can say that, then I guess my patients in rural Pakistan can say that too. So that's just the vaccine stuff. All right, the references have links to our elective sites as well. And that is it. I thank you for your time. I'm happy to take questions, entertain challenges, and so forth.
And there's a list in the back too, if you sign in and put your
Good.
email, we'll make sure you get on our global health list.
Please. And again, thank you to Global Health Track residents and faculty who really make this work, make it tick, make it happen. So, come back next time. Yes.
I know it's been discussed before that, there is a tropical disease, they still call the tropical disease hospital in London, United Kingdom. Would it be worth approaching them formally to be one of the places where residents or people who are on the track, would they be able to accept people? Because they have done in the past. I'm talking about many, many years ago. Some universities in America, we had students there at that time.
Yeah, sure. Well, a little more than 10
I
years
really
ago.
feel that, to be trained in what we used to say tropical medicine, and you need to be exposed, not actually, because it's very difficult to be exposed to them unless you travel to different countries. But a unit like that does provide you experience in, multi-specialty. I think you know it yourself. So I don't know what my suggestion was, to take it up formally by, talking to them.
I think it's a very good idea. As Dr. Thani mentioned, I was actually at the HTD many years ago, and he was at the HTD many years ago as well. And this is the hospital, and it's run by now the University College London Hospital. It is probably the best clinical training site for tropical disease in the Western world. I emphasize that because they have an amazing unit. It's basically one floor of a hospital. They'll see things like inpatient malaria is bread and butter. but they'll see things like lupus vulgaris, which is a dreaded, side effect, not side effect, but a complication of tuberculosis. They'll see schistosomiasis, they'll see trochanculitis, guinea worm, you name it, it's probably been through there at some point. And they will frequently have the only expert on that tropical disease working in the country will be posted there. And so Dr. Gilani is correct, you really cannot study tropical disease clinically in this country. Fortunately, we don't have any. So how are you going to see it except the occasional malaria case that wanders through? This really shows you the approach to treating disease. Setting up a partnership with them, I think, is a really good idea. I think they have never set up a partnership with anybody. Not Johns Hopkins. The only school they have one with is their partner, the London School of Hygiene and Tropical Medicine. And I think it is definitely worth exploring. I think that we should put that on the agenda as we explore electives this year, thinking about what it might mean to do that. If we can find a willing resident who would be piloting it out for us, I can guarantee you it would be